Welcome to today's iReview session. My name is Yejun, a second-year medical student at the University of Calgary. Our team here will present to you today about AAION, Arteritic Anterior Ischemic Optic Neuropathy, as a link between ophthalmology and emergency medicine. The field of ophthalmology and emergency medicine is quite intimate. Around 2 million visits to the emergency department every year in the US are from ophthalmic conditions. And the topic we are going to cover today, giant cell arteritis, which is an arteritic AION, is an emergency. This is one of the reasons why people go to the ED. This unique and emergent ophthalmic condition, known as giant cell arteritis, is also associated with other medical fields as well. Polymyalgia rheumatica, which is a disease in rheumatology, is also associated with scalp tenderness and temporal pain, and indicated with vasculitis known as giant cell arteritis. Another link can be drawn between ophthalmology and neurology. GCA causes Arteritic Anterior Ischemic Optic Neuropathy, or AAION. This is essentially an impairment in the optic nerve. So this disease that's quite mouthful. What is an AAION? So it's an arteritic category. There's also a non-arteritic AAION, but in this case it's an arteritic category of the ischemic infarction of the anterior optic nerve. Right? So there are vasculature feeding the optic nerve as well, and the anterior segment is suffering from ischemia. And there's an occlusion of the posterior ciliary circulation, which feeds the anterior optic nerve, and this is behind the lamina cribrosa of the optic disc. The arteritic classification is due to the giant cell arteritis that occurs. So with giant cell arteritis or temporal arteritis, you'll get scalp tenderness, the jaw claudication or tiredness from using the jaw repeatedly over a long period of time, and also temporal pain. Let's take a look at the vasculature where AAION and the GCA can occur. So there's the internal carotid artery leading from the heart all the way up into the neck and into the head. This turns into the temporal artery as it crosses the temporal area of the head, which then branches out into an ophthalmic artery and then to the posterior ciliary arteries that feed the optic nerve. People at risk of AAION are patients over the age of 55 or patients with polymyalgia rheumatica. Polymyalgia rheumatica is an inflammatory disorder that causes widespread aching, stiffness, and flu-like symptoms. And the most common presentation of polymyalgia rheumatica is the pain and stiffness in the shoulder muscles, as well as the necks and the hips, and also the morning stiffness. Here are some of the symptoms of AAION. This commonly occurs as an acute unilateral and painless vision loss. There's a triad of scalp tenderness, jaw claudication, and the temporal headache that I mentioned earlier that's associated with giant cell arteritis. The AAION can come with B symptoms such as fever and weight loss, and it can also occur with dyschromatopsia or loss of color vision. Polymyalgia rheumatica does not always happen with AAION, and also AAION doesn't always happen with polymyalgia rheumatica. This is a joint pain and inability to lift the arms beyond 90 degrees, so girdle limitations of the range of motion. The AAION, because it's unilateral, can also present with diplopia. And the history of transient vision loss needs to be ruled out because amaurosis fugax can accompany this disease as well. With AAION testing visual field, you'll notice that the patient often has central or altitudinal visual field defect. Upon observing the pupils, the patient will have an RAPD or a relative afferent pupillary defect. This can be confirmed by a swinging flashlight test. While normally on perception of light and stimulation of the optic nerve after that, the pupils will constrict in response. However, if the light sensing system, the cranial nerve 2, is impaired in the other eye, upon shining light at that eye, the fellow eye will receive less light in comparison. This will result in dilation of the pupils instead of the maintenance of constriction. When observing the back of the eye with fundoscopy, there may be swollen optic disc as well as swollen and tender temporal artery upon physical exam. On back to fundoscopy, you also find cotton wool spots indicating ischemia, and in the late stage, you'll find optic disc cupping and elevation. With these symptomologies, AAION has a lot of differential diagnoses. It can be malignant hypertension, which is resistant to a lot of hypotensive meds. There could be diabetes mellitus, retinal vascular occlusion, the BRAO, compressive lesion from the back of the eye. There can be collagen vascular disease, always syphilis, as well as herpes zoster. Systemically, there can be migraine or massive blood loss that can cause these symptoms, and also normal tension glaucoma can present with decreased vision or constricted visual fields in the late stage. So the history and the physical exam that will be important to rule in AAION is the ophthalmic history, paying attention to the erectile dysfunction drugs, amiodarone, and the obstructive sleep apnea, so ask them about sleep quality, and also if someone else had come with them, any signs of obstructive sleep apnea. Physical exam, we can check the visual acuity, color vision, as well as the Amsler grid. This is demonstrated in the top right picture there. If on any point of the grid the lines are wavy or discontinuous, this signifies a problem. And also look for pupils and test test for RAPD with the swinging light test, as well as ophthalmoscopy. Make sure to do a fundoscopy as well. If you're suspicious that the patient has AAION, ESR and the CRP is crucial. We should investigate those two markers as soon as possible. In terms of vitals, we can take blood pressure. That's especially important. We can also order CVC, look for low hematocrit and high platelets as an acute phase reactant. Also look for fasting blood glucose for diabetes mellitus possibly, and VDRL and FTA absorption test for syphilis, and ANA for vascular inflammatory disease. Further investigation upon confirmation of suspicion can be temporal artery biopsy. This may be inaccurate because GCA forms skip lesions on the temporal artery, so the lesions are not continuous. We can also investigate with the fluorescein angiogram for any choroidal infarct. choroid is the layer right outside of the retina, divided by the Bruch membrane. Treatment of AAION is systemic steroids. You can give methylprednisolone IV 1 gram per day for 3 days, and it's important to check the blood glucose and the chest x-rays before that. Steroids tend to increase the blood glucose and suppress the immune system so that the chance of pulmonary infection is more likely. So it's important to make sure that the blood glucose is well controlled and there are no pulmonary effusions or any symptoms of focal lung infections before administering steroids. If there are, and treatment is crucial at this point, we need to manage these conditions as well. After methylprednisolone, we switch over to prednisone at 60 to 100 milligrams per oral each day and taper it off very slowly. We cannot decrease it more than 2.5 to 5 milligrams per week. Otherwise, the patient can go into steroidal withdrawal syndrome. Because the AAION is an emergency, the steroids can be started before the biopsy results are seen. For systemic steroids, it would be thoughtful to add an H2 receptor blocker or a PPI because there is a slight risk of a peptic ulcer with steroids. Unfortunately, AAION has quite a bad prognosis. The visual recovery is rare, and the treatment will hopefully prevent the progression of the visual impairment. And the fellow eye is also involved in 75, 3/4 of the cases, and if not treated, as quick as within 2 weeks. Here is a well-drawn flowchart to demonstrate everything that we've learned in this presentation. And here are the references for that we've used to compile all the information in this presentation. Thank you for watching this video.